Hi everyone, good afternoon. We're getting started in just a minute as folks are starting to come into the Zoom call. Thanks for joining us this afternoon. Hi, welcome to today's webinar. This is Lori Smetanka. I'm the Executive Director of the National Consumer Voice for Quality Long-Term Care. And this is the 12th installment of our webinar series, COVID-19 Advocating for Nursing Home Residents, sponsored by the Consumer Voice, the Center for Medicare Advocacy, Justice and Aging, and the Long-Term Care Community Coalition. Many of you have been joining us over the last couple of months as we've been hosting these webinars to keep you updated on the latest information, guidance, and actions at the state and federal levels related to COVID, to talk about the impact on residents of long-term care facilities, share resources, and offer recommendations for advocacy. Next slide, please, Libby. Over the last couple of weeks, the Centers for Medicare and Medicaid Services, or CMS, has issued some new guidance. One is related to survey activities and enforcement, both of which have mostly been suspended with limited exceptions since March. And also they've released new interim rules and guidance related to COVID testing. So we're going to be hearing about both of those things today. And we're also going to be talking about visitation. We know that's a really important topic for many of you. It's one of the areas we get asked a lot of questions about, and so we're going to give you updates on what's the latest that's happening with visitation in the states and at the federal level. And then with any remaining time, we'll open for questions and discussion. So next slide, please. Today's speakers are Toby Edelman, Senior Attorney with the Center for Medicare Advocacy, Eric Carlson, Directing Attorney at Justice and Aging, and Robin Grant, Director of Public Policy and Advocacy here at the Consumer Voice. A reminder that today's webinar is being recorded, and the recording and slides will be emailed out to all participants over the next week and will also be posted on the Consumer Voice website. You can also find the recordings and slides from the previous webinars in this series on the Consumer Voice's website. We'll be in just a minute putting the link to the slides for today's presentation in the chat box, and you'll be able to link to them or download them from there. As a reminder, all lines will be muted throughout the webinar. Please post any questions for the presenters in the question and answer box on your control panel, and please use the chat box to make any comments or discuss points among yourselves. And with that, next slide, please. I'm going to turn it over to Toby to get us started on the presentation today. So Toby.
Okay. Thank you, Lori. So what I'm going to talk about this afternoon is the new survey and enforcement guidance from CMS. Next slide, please. CMS issued this guidance on August 17th, so it's just last week. Next slide, please. What I've put here in this slide is the official name of this survey and certification letter, and its date and number and the URL. So please feel free to go look at it. This is a very complicated, to me at least, topic, and I wanted people to have this information in case they want to go check it out themselves. Next slide, please. The next part is just the press release that CMS issued when it released this new guidance. Next slide, please. So to understand what's happening now, we need to go back to March of this year. In March, and as of March 23rd, CMS suspended standard and complaint surveys, the annual and the complaint surveys. And what it said it would do going forward was have states conduct only focused, or also known as targeted, infection control surveys. So surveys that looked only at infection prevention and control practices, and complaints or facility reported incidents that states identified and classified as immediate jeopardy. Now, as we know, immediate jeopardy is the highest classification of non-compliance, and about 1% or less of deficiencies are ever classified as immediate jeopardy. So the intention from March 23rd was that not a lot of surveys were going to be going on. These are the QSO 20-12 and 20-20 are the two letters from CMS that explain the survey suspension. Next slide, please. In June, CMS liberalized its guidance about surveys a little bit, and it said when states got to phase 3 of the reopening or earlier at state discretion, they could begin to do additional surveys. So they could do complaint surveys that were not immediate jeopardy, but they were considered high importance. Revisits where jeopardy had been removed, but the facility still remained in non-compliance. And then recertification of special focus facilities and candidates for the special focus facility program. So that's about 500 facilities in the country that have a history of very, very poor performance over a long period of time, several year period of time. Next slide, please. So now the new guidance for August 17th. What CMS says about surveys is that as soon as states have sufficient staff and sufficient personal protective equipment for the surveyors to use, then they can conduct on-site revisits as are specified in the State Operations Manual. That's the guidance that surveyors use to conduct surveys, tells them how to do surveys, for surveys that ended on or after June 1st. So go back to the normal survey conduct starting June 1st. Of course, they said this August 17th, but that's their position, June 1st. They said surveyors could also look at complaints that are triaged as non-immediate jeopardy, but of medium significance, so that's not high, but medium, and then annual recertification surveys. Next slide, please. So what does this mean? Well, states could resume surveys according to pre-COVID requirements for the surveys that ended on or after June 1st, and they're supposed to resume normal recertification surveys, but only if the state agency has enough survey staff and enough personal protective equipment. Advocates have been really urging CMS to restart normal surveys, the standard and complaint surveys, as soon as possible. So that will be happening, but there could be delays, of course. And we know that there are some states, certainly California has not been testing its survey staff, so there are going to be delays in states, but it's an important and positive change. Next slide, please. So now to the more difficult part, which is enforcement, and back to March 2020. CMS suspended all enforcement activity with the exception of facilities that were still cited with immediate jeopardy. If that was happening in the facility, if the facility had been cited with immediate jeopardy, surveyors would go out. But what this suspension of enforcement meant is that it was suspending revisits that would end ongoing enforcement cycles. And CMS told facilities they didn't need to submit plans of correction. Next slide, please. So a little bit of explanation about enforcement cycles and plans of care, plans of correction. This is why this is quite a complicated part. Usually an enforcement cycle begins when the surveyors cite a deficiency, and it ends when the facility returns to substantial compliance. So there is a period of time where the facility may not be in compliance. If there is an additional survey during that period when the facility has not returned to substantial compliance, any surveys and deficiencies are considered to be in the same cycle. There has to be a point where the facility has come into substantial compliance with all the deficiencies that are cited in that time period. Now what they're saying now, what CMS is saying, is that if the survey had an exit date after March 23rd, that is a new survey cycle. And the meaning of that, I hope, will become a little clearer in a couple of slides. Next slide, please.
Toby,
So,
can you make sure you're very close to the microphone,
okay.
please?
I'm
Thanks.
getting closer. Okay. Enforcement cycles are also important because they have two mandatory penalties. Generally, an enforcement is discretionary. So if a facility has a deficiency, CMS and the states have authority to impose a penalty, like a civil money penalty, but they don't have to. But there are two mandatory penalties. So if a facility has not come into compliance within 3 months in the survey cycle, then there is a requirement for denial of payment for new admissions. If the facility doesn't come into compliance within 6 months following the survey, then it is terminated. Those are mandatory penalties. So it was important to CMS to stop that survey cycle with these new targeted infection control surveys. That's why that was important. Next slide, please. Plans of correction are also what facilities need to submit when they're cited with deficiencies. They need to say how they're going to fix the problem for the identified residents and the other residents with the same problem, try to make sure that the problem does not reappear. And as I said a couple of minutes ago, CMS said facilities did not need to submit plans of correction. Next slide, please. So CMS has this new guidance from August 17th, and it had several purposes. It wanted to resolve the enforcement cases that were suspended. What do we do about these cases where there were deficiencies out there, but there were no surveys to determine whether the facilities had come back in compliance? That was one important point. They wanted to talk about how to close out those cases and what should happen going forward in the future. That's June 1st and after. Next slide, please. So there are 4 components of this new guidance: expanded desk review for plans of correction, and then information about—
Excuse me, Toby, could you get a little closer to your—
Closer than that, I'm going to be eating my computer soon.
Yeah, I'm sorry. Maybe you're off to the side just a little bit or something, because you're a little bit muffled right now.
Okay. All right, I will slow down.
That's
and get
better right there.
Okay, right here, I won't move. Then they wanted to talk about how to process the enforcement cases in 3 categories: cases before March 23rd, before they suspended regular surveys; cases that began between March 23rd and May 31st. That was what they called the prioritization period; and then cases after June 1st. Next slide, please. So what facilities have to do for all deficiencies that were conducted before June 1st is submit a plan of correction within 10 days. If the facility is currently having a COVID outbreak, it can ask for an extension of time to get more than 10 days to submit a plan of correction. Next slide, please. This is the most important change and the most troublesome one, I think, of everything in this guidance, and it's expanded desk review. Under desk review, the surveyors don't go out on site. But what CMS says, if the facility submits a plan of correction with supporting evidence, and if the desk reviewer at the state survey agency says that's acceptable, then it can clear all deficiencies that were cited before June 1st, including actual harm deficiencies. And the surveys where facilities had immediate jeopardy was removed, but it still was out of compliance. All of those can be cleared with this desk review. And what CMS says as an example of the supporting evidence is documentation about training. Well, that's particularly troublesome because facilities often say in the plan of correction that they're going to train the staff. But especially in quality of care deficiencies, surveyors want to go back to make sure that the staff actually learned what they were taught in training and know how and do apply it in the day-to-day care they provide to residents. So our residents doing a good job, that can only be determined by being on site. But CMS now is saying for these surveys before June 1st, everything can be cleared through desk review. Next slide, please. Now, this is inconsistent with the current state operations manual, which says that if actual harm is cited for immediate jeopardy or substandard quality of care, then there must be an on-site revisit. Even if the deficiencies, the harm, jeopardy, and substandard quality of care, even if those deficiencies are reduced to a lower level of noncompliance, there must be a revisit. In this desk review now from the August 17 memo, CMS is saying no, don't need to have an on-site revisit. Desk review will be sufficient. Next slide, please. This is substandard quality of care. It's a very long list of regulations, and you can see at the very bottom, even if it's category F, which is no actual harm, the potential for more than minimal harm, widespread, that is substandard quality of care for these various regulatory provisions. Under normal times, an on-site revisit would be mandatory. CMS is now saying clear these. They can be cleared through desk review. Next slide, please. So expanded desk review really means that they're not going to have on-site revisits for these types of surveys, for these types of deficiencies cited during this time period. And I think it's very troubling because a lot of deficiencies that were cited before the pandemic, and I've been in a survey cycle from January or February, they're going to be cleared to move on. Next slide, please. So there are 3 different categories of enforcement cycles, the ones that started before March 23rd. This, I think, is probably the most confusing part of the memo. But if the remedies, if the notice hadn't been sent, but it was not final because there hadn't been a revisit, these are deficiencies before March 23rd, then there can be CMPs and denials of payment for new admission through March 23rd or the date of substantial compliance, as set out in the plan of correction and verified by the desk audit, whichever is earlier. So I thought if the facility said, okay, here's our plan of correction, we actually came into compliance April 1st, this would say, well, the CMP would end March 23rd anyway, because that's earlier than the date you say in the plan of correction. Next slide, please. There's a slightly different language about facilities that were started before March 23rd if the notice of remedies had not been sent. But again, it's the lesser of the CMP is the lesser of the time through March 23rd or the date of alleged compliance. Next slide, please. For March 23rd through May 31st, May 31st, the prioritization period, again, desk review could close the survey cycle, and there will only be CMPs for actual harm or immediate jeopardy deficiencies. That's like 3%, 3 or 4%. If there's actual harm, it may only be a per instance CMP, even though CMS's own guidance on this says sometimes there needs to be a per day CMPs. But what this time period says is that there will be no CMPs for any deficiencies that are lower than harm or immediate jeopardy. You know, the 97% of deficiencies that are typically cited. Now, of course, not during this period, presumably because they were only looking at targeted infection control and immediate jeopardy. Next slide, please. There's also a provision that there will be an automatic 35% reduction in the civil money penalty if the facility had been unable to file the written notice of appeal within the 60-day time frame during that period, March 23rd to May 31st. Now, the rules actually say that CMPs can be reduced by 35% only if a facility informs CMS in writing that it is not appealing. Last July, CMS proposed to change that, but that proposed rule has not been made final. But by this guidance document, CMS is reducing those penalties for that time period automatically by 35%. Next slide, please. So I think this guidance about, oh, of course, last thing, for enforcement cycles starting on or after June 1st, the regular enforcement process is back in place as set out in typical surveyor guidance. But CMS says that CMPs that are imposed, the per day CMPs, begin on the day of the survey. That is also contrary to the regulations, which allow CMS to start the CMP at an earlier date if the surveyors can actually confirm that the facility was out of compliance at an earlier date before the start of the survey. If they can confirm that on the survey, CMP can start before the survey. But CMS is saying now, for surveys after June 1st, no. Per day CMPs, to the extent they are imposed, need to start on the day of the survey. Next slide, please. So what does this all mean? Well, I think we're primarily concerned about the expanded desk review because they're going to clear a lot of deficiencies that were cited earlier in the calendar year. And there may not really be, from our perspective, sufficient evidence that the facility really did come into compliance. So I think a lot of things are going to be swept under the rug. I think I'm also concerned about the limitations on and reductions of the CMPs because I think facilities won't have the civil money penalties that might be appropriate during the pandemic and beyond. So to me, it looks like CMS is loosening enforcement, which has always been the weak link in the nursing home reform law, loosening it even more. Last slide, please. So I wanted to end with something positive, and that's good news about the targeted infection control surveys. On August 26th, CMS issued a revised protocol for targeted infection control surveys. And for the first time now, these surveyors are going to have to look at a sample of residents and a sample of staff. That has not been required in these targeted infection control surveys. And as we know, looking at them, they're released the last Wednesday of the month through Nursing Home Compare. There's a link on Nursing Home Compare, and we have been evaluating them every month. This is the fourth time CMS has released them. They're between 2 and 3% of targeted infection control surveys have been citing an infection control deficiency, according to what CMS is releasing through that website. That's been very troubling, and one of the main causes, I think, is that surveyors really have been doing a very quick job. They've done several surveys on the same day, so they're not spending a whole lot of time. But I think a big problem has been that they're not looking at resident staff interactions, asking questions. Do you have an infection control policy? Do you have an infection preventionist, at least part-time? Well, those are, you can answer the questions, but the essence of a survey is always how what the surveyors observe and figure out about how residents in a sample are being treated by staff and whether they're getting the care they need. So the new survey protocol, the revised survey protocol, is requiring surveyors to look at these samples of residents and samples of staff, including one who has COVID for each of the samples. So I think that's a positive step. And now I'd like to turn this over to Eric.
Terrific. Thanks, Toby. Let's move to the next slide, please. I'm going to start talking about testing. I want to suggest it's actually a big deal. All of us, I think, are aware of testing being a missing piece in nursing facilities or maybe in any setting in the United States over the last half a year or so. Without testing, all of us are flying a bit blind, and that's obviously had particularly devastating consequences in nursing facilities. And now we're getting beyond that, given what may be increasing access to testing. CMS is imposing a requirement on facilities to perform tests for COVID-19. The next slide, please. This is through a revision of regulations. I'm going to be talking about 2 revised regulations today. The first deals with testing, and the second deals with money penalties for violation of reporting requirements. Each of these is done as an interim final rule, which means it's effective essentially immediately or a couple days from now after publication in the Federal Register. So we can consider these as effective immediately, but then also understand that there will be a comment period. So we will have 60 days to submit comments. In the meantime, during the comment period, and while CMS is considering those comments, the current version, this interim final rule version, will be effective and enforceable against nursing facilities. Next slide, please. Now, under this regulation, which is the infection prevention regulation, it's been revised to require testing. Under the regulation, the facility has an obligation, which we'll describe in a little bit more detail, to test residents and staff members for COVID-19. The description of staff is extremely broad, includes registry workers, volunteers, almost the broadest possible interpretation of what might be considered staff in the nursing facility, which is, of course, appropriate under the circumstances. Next slide, please. There's also mentions of some other folks who are likely to have some contact with the nursing facility, with nursing facility residents. The surveyors, that's the state's responsibility. And as I think Toby mentioned, that there's some issues about that. It was in the paper just earlier this week about California still not getting their own surveyors tested. But in any case, for reasons I think we can probably understand, that's not the nursing facility's problem. It's the state's responsibility to make sure that the surveyors have testing. And then regarding visitors, you'll see the language here in the slide. What CMS guidance says at this point, it's not required, but facilities may test the residents' visitors. So that's where it stands. The regulation doesn't require testing of visitors. Next slide, please. Under the regulation, and understand that the regulation is meant to set the basic standards, and the details are going to be set by guidance. The guidance in this case was also issued this week, but the guidance may be modified a month from now, 6 months from now, whenever, to reflect, for example, greater knowledge of COVID-19 or observations of how things have played out, to make those detailed changes, even though the regulation may be more set in its language. So under the regulation provides fewer details, but lists what the CMS guidance must cover, which includes all these things here: frequency of testing, identification of persons who were COVID positive, who have symptoms, criteria for testing asymptomatic folks, response time, and other relevant factors. And I'll talk in a couple of minutes of the specifics that have been provided by the guidance this week. Next slide, please. Also under the regulation, there's a specification that the facility must document. And for staff, the documentation has to include test and results. For residents, has to include that the test was offered, whether it was performed, and then the results. And the guidance then has significant details for nursing facilities in order to carry out these requirements right now, regarding the dates, the symptoms, and it specifies a different kind of documentations and how those requirements might be applied differently for staff, for example, as compared to residents. Next slide, please. And then, in a way, certainly we can understand the facility has to take steps in response to the test results. And these, I think, won't surprise anyone listening to this webinar, that if staff members are positive or have symptoms, they shouldn't be working. They need to stay away from the facility. For residents, there need to be transmission-based precautions. For example, the cohorting, essentially keeping people separate based on their COVID status, and that should include keeping staff separate as well, so that staff, their responsibilities are limited to caring for just COVID positive folks, or just with those folks that are believed to be COVID negative. Next slide, please. The guidance lists the type of test. Just to set the background here, I'll mention it. The couple of types of tests that are set up to detect the active virus. These are the molecular tests, and then the antigen tests. There's also mention of the antibody tests. There's an important distinction here, of course. The antibody tests measure whether the person essentially has had an infection in the past, not whether or not he or she has a current infection. Next slide, please. Under these current requirements, the testing can be done at the facility. This is so-called point of care testing, or in an off-site laboratory. But if that's the case, there has to be a reasonably quick turnaround in test results, which is specified within 48 hours. The guidance also requires that screening continues, so the fact that there be testing does not limit in any way the nursing facility's continuing obligation to screen people as they enter the facility. Check for symptoms, take temperature tests, things like that for staff and residents and others who may enter the nursing facility. Next slide, please. And so that moves us to the standards on how frequently tests should be done, when they should be done, and how frequently. There's 3 categories listed here: the symptoms, the outbreak, and the routine. The first is that residents or staff members, if they present symptoms of COVID-19, need to be tested. Makes perfect sense. Then the so-called outbreak standard, and outbreak is maybe a little bit of a misleading descriptor of this. Outbreak just means a single case. And a single case, though, breaking out in the nursing facility. So if a nursing facility accepts a resident from the hospital, for example, who has COVID-19, that's not an outbreak in the facility because there's not a record of transmission within the facility. But if there is a record of transmission within the facility, a new case within the facility, then these outbreak testing standards come into effect. And in that case, every staff member and resident need to be tested every 3 to 7 days until there's no positive test for at least 14 days. Next slide, please. And then the third situation, as I mentioned, is the so-called routine situation. So this is our new normal, as it were. If no symptoms, we'll assume no outbreak, just status quo. And in that case, the facility has to do a reasonable level of routine testing to make sure that the COVID infections don't sneak up on them unbeknownst. The requirement of testing depends on the positivity rate in the county, and you'll see that listed here. If the positivity rate, number of positive cases, percentage of positive cases, rather, in the community, if it's less than 5%, the nursing facility has to be testing at least monthly. If that positivity rate is between 5 and 10%, tests have to be done at least weekly. And then if the positivity rate is greater than 10%, then the nursing facility has to be conducting these tests at least twice a week. The nursing facility is obligated to check on the positivity rate at least every other week. And those rates are available at the website listed at the bottom of the slide. Next slide, please. There's some specifications in the regs and the guides about what to do when testing is refused. The first is just the common sense suggestion is to give the resident, for example, some options. That some of the methods for collecting samples are not particularly pleasant, and it's possible that the resident may change his or her mind if given an alternative. But if the resident refuses the test, the resident has symptoms, it has to be put under the transmission-based precautions. And otherwise, if there's no symptoms, but there's been at least one case, then the facility is instructed to, in the language of the guides, to be extremely vigilant to make sure that the resident acts with appropriate protection, the kind of physical distancing that we're familiar with, the face covering, etc. Next slide. And then similarly, if a staff member refuses testing, if she has symptoms, shouldn't be in the facility. Also is barred from the facility if there's the so-called outbreak, if there's a new case, or if there's some record of transmission within the facility. And then otherwise, in routine situations, the facility is instructed to follow local policies as to what to do with the staff member who has refused testing. Next slide, please. And then there's also mention of the guidance, and I understand here I think there's still some ambiguity as to what the prognosis is for somebody who, once he or she is tested positive, what that means for immunity. CMS cites the CDC here, the Centers for Disease Control and Prevention, and states that there's no need for a retest within 3 months of the person's first symptoms. Next slide, please. And then that brings us to the second interim final rule, and this enforces some requirements that went into effect a couple of months ago. Next slide, please. You're probably familiar with these. These have been in effect since May. Facilities has to make weekly reports on COVID-19 status to the CDC, and then the information is available through Nursing Home Compare. Next slide, please. And this is the information that has to be provided through that system. You know, COVID-19 information regarding the status of residents and staff as to infections and to death, and then also some logistical information regarding the facility, whether it's got enough supplies, essentially, whether it has enough staff members, and then how big the facility is too, so that the public and the CMS and the state survey agencies have some sense of what's going on in that nursing facility. Next slide, please. And this is just, I pulled this off the website. This facility I just pulled out randomly yesterday. It's within 100 miles of where I live, and I just happened to click on it to just show you the kind of information that's presented through the Nursing Home Compare connection on the website. And I'll just say, and this is completely random, I think the one I happen to pull, the data is wrong. If you look at this, the numbers here, I won't belabor it, but the numbers don't make any sense regarding 789 deaths per 1,000 residents. It's so it's indicative of some data problems, some continuing data problems with the data set on the website, and it's understood that that's a work in progress. Next slide, please. So this is what's through the interim final rule, and it just formalizes the guidance that was put out a couple months ago. The guidance announced civil money penalties is going to be cited at the F scope and severity, which means there's a widespread scope. If this is a facility that fails to report, they've got an obligation to weekly report this information. Let's assume the facility fails to do that. That's an F citation, because the violation is deemed a widespread, not just relating to one resident, but it's broader, but the severity is listed as no actual harm with a potential for more than minimal harm. Next slide, please. And then that, per the guidance of a couple months ago, is formalized by this new interim final rule, $1,000 fine for the first violation, and then that increases. If you, another violation, it is $500 higher, so that's a $1,500 assessed at that point. If the facility violates it again, that's another $2,000. Another mistake is $2,500. It's theoretically, I think actually the CMS notes that there's been 98% compliance. But if a facility did repeatedly fail to report adequately, those would be the consequences. Next slide, please. And this is effective immediately, these interim final rules. And CMS notes that although most of this would expire at the end of the public health emergency, whenever that might be, the CMP regulation would last at least a year longer to allow for enforcement of these requirements appropriately. And with that, I'm going to turn control over to Robin to talk about some visitation issues.
Thank you, Eric. Because we are all so incredibly concerned about the devastating impact we're seeing from the separation of residents and families, we wanted to take a look this afternoon at where we are with visitation, both in states and nationally. Next slide, please. So I think at the state level, I can sum up where things are with one word, and that is inconsistent. I know this comes as no surprise, but visitation policies and practices are different from state to state. They're different from facility to facility, and they're different in reality from what they are on paper. Next slide, please. So here's just some of what we're seeing and hearing about state visitation. But I do have to preface it all by saying there's a big yes, but. Yes, but ultimately everything is up to the individual facility. So for the most part, we are seeing that facilities are continuing virtual visitation and window visits, although we are hearing about facilities that have ended window visits, and we're certainly hearing about how virtual visitation is not working for a number of residents, and particularly residents with dementia. In terms of outdoor visits, approximately 2/3 of states are permitting outdoor visits. So what that means is that on paper, outdoor visits are permitted. And the criteria for those visits, again, varies from state to state. So in some states, outdoor visits are allowed when COVID-19 is actually present in the facility, while others say that the facility has to be COVID-free in order for there to be even outdoor visits. So again, all sorts of inconsistencies. You can have a state policy that permits outdoor visits at the same time that you have many facilities just deciding not to allow them, and the state doesn't do anything about it. There are also states that say outdoor visits are permitted, but they have so many qualifications and criteria that have to be met that these visits almost never occur. And one of my favorite examples of this is Indiana's policy, and I can actually, I'm allowed to call out Indiana because it's my home state. So not just trying to pick on it. Next slide, please. But this has so many levels of qualification. So it starts off by saying outdoor visitation is now required. And I read that and went, oh gosh, this is wonderful. And then the yes buts. But the facility has to be in a county that is beyond Indiana's own stage 2 criteria. The facility has to have no new onset COVID-19 cases within the last 14 days. It has to meet certain facility and community conditions. And of course, the weather has to permit. And then the big yes, but it gives facilities basically total control over deciding if they're going to have it or not, because the circumstances, in their opinion, pose a harm or risk. So by the time you get through all that, it can be very unlikely that there will be a lot of outdoor visitation. And yet, because I don't always want to be a Debbie Downer, I want to share a state example where outdoor visitation actually does appear to be required, and I have not been able to find any yes buts. So next slide. In California, at least on paper, it says that facilities that can't meet conditions for indoor facility visitation and their requirements, California lays out what those requirements are, but it says if a facility can't do indoor visitation, it shall provide outdoor and other visitation options. So I think the shall is pretty exciting. Of course, I guess if a facility refuses to permit these visits, then you're going to need the state survey agency to enforce that requirement. And we know often how that goes. But the shall at least does seem to give some leverage. But I guess I would say that as welcome as outdoor visits can be, they are very limited, or they can be very limited. You know, not all residents can go outdoors or want to go outdoors. And also outdoor visits can be canceled if the weather is bad. And in many parts of the country, the weather is very soon not going to be conducive to outside visits. So that leaves indoor visitation. Next slide, please. So you'll remember that CMS has recommended that nursing home reopening be done in 3 phases. and that there should be no indoor visitation, according to CMS, until it's phase 3. Well, once again, states are all over the place with what is required for indoor visitation. So many states have actually adopted, in essence, those CMS recommendations. At the same time, a number of states have developed their own phases and criteria. So one example, in Montana, the governor has said that visitation indoor may now be allowed because the state is in its own state-specific phase 2 of reopening. Still, other states permit indoor visitation, but you have to meet certain conditions. Next slide. So this is an example of what Tennessee requires. I won't read off all the requirements. You can see what they are, but the bottom line is, given all of those requirements, there basically is no indoor visitation right now in Tennessee. And yet, there is a positive in this. Next slide. I have heard that at least one state, and I'm hoping that there are more states than that, but we've heard at least that one state, Rhode Island, is actually permitting indoor visits. So they are not unheard of. And we do know that there are, in some of these states, facilities that are COVID-free that, in fact, may be allowing indoor visits, but this certainly is the exception rather than the rule. Next slide, please. There are a growing number of states that are permitting indoor visits for some kind of a support person, if you will. The term for this varies. It's being called sometimes an essential family caregiver, an essential caregiver, or essential support visitor. The role of this person, regardless of what the term is, appears to be to provide a resident with companionship, and or emotional support and or assistance with activities of daily living. So there's kind of a range of support that these individuals can provide. So far, there are 5 states that we know of that have this kind of a person: Indiana, Minnesota, New Hampshire, New Jersey, and South Dakota. And since there are different terms that are used for this kind of a support person, I'm just going to use the term essential caregivers. That's what 2 states call them, so I decided to just use that so that I wasn't switching terms around. So within these 5 states, there are a lot of similarities between these essential caregivers, but there are also some important differences. So to make them easier to compare and contrast, I created a chart. So next slide. So that's the good news. There's a chart to make it easier to compare. The sad news is that I wasn't talented enough to be able to figure out how to put everything on one slide without making the font so tiny you couldn't read it. So this chart actually takes up 3 slides. So we will be sending the slides out to you, and you will be able to look at the full extent of the chart. But for now, I'm just going to summarize the information so we don't have to go back and forth between 3 slides. So 4 out of these 5 states allow the essential caregiver to come in during any phase of reopening. To be eligible to have or to qualify, if you will, for an essential caregiver, all the states require that the resident has to be COVID negative. And in terms of other criteria, that kind of varies. In some states, all residents are eligible, period. In one state, the criteria is not specified, so you don't really know. And in one state, the resident has to be a high-risk resident who is missing care that was previously provided by a loved one or another caregiver. So the next category on the chart is whether the decision about allowing an essential caregiver is up to the facility. So no surprise here. Every single state says, in every single state, that decision is in fact left up to the facility. Totally a facility decision. And then in terms of requirements to be an essential caregiver, in 2 states, it has to be a person or a friend who previously was actively involved in providing companionship or care. In 2 states, the requirements are up to the facility. And in 1 state, the requirements aren't specified. And I would add that in 1 state, the essential caregiver has to have a COVID negative test in order for their time to be scheduled in the facility. And finally, the number and length of visits permitted is different according to the state. 3 states have specific limits on the number of visits and the length of the visits. In 1 state, it's actually determined by the essential caregiver themselves, and in 1 state, it's not specified. So we see different things, but we are definitely seeing a growing number of states creating this, this essential caregiver, and I think we will be seeing more. So that is some of what we know is happening in states. I also want to update you on advocacy that's going on at the national level. One thing we can say for sure, that's good if you just stop there, that's perfect. I'm not talking about this slide, I'm just sort of giving some other background about national advocacy. I do want to say that there is growing pressure on CMS to ease restrictions. So some of what's been happening, you have advocates have been pushing for months to get CMS to clarify, for example, guidance around compassionate care, to let more families visit their loved ones. Many of you probably know there was a nationwide social media day that was led by California Advocates for Nursing Home Reform as part of its Visitation Saves Lives campaign, in which a lot of individuals and organizations, including Consumer Voice, participated. Families have been very active and have come together really organically across the country, formed groups, and are actively pushing for visitation. And while we don't yet know what the Nursing Home Commission has been doing or saying, it is pretty likely that this subject has come up. So we may be seeing something from the Commission about this. So the net result is, okay, next slide, please. There's a ray of hope. It's clear that speaking up matters because we have heard CMS has said that it will be issuing new guidance on visitation. And that is a very big development. And I want everybody to take credit for having helped move CMS on this issue. Next slide. So last week, CMS asked for input and recommendations from a small group of advocates that participate in regular calls with CMS, its Division of Nursing Homes. And that small group consists of Consumer Voice and all the groups on this call, or who are offering this call, Justice and Aging, Center for Medicare Advocacy. Also, California Advocates for Nursing Home Reform and the Long-Term Care Community Coalition. And I do want to add that NASOP also, the National Association of State Ombudsman Programs, also had input. But CMS gave us a little over 24 hours to get recommendations to them, which we were able to do, and I'm going to talk about them in just a minute. But we emphasized to CMS that this was just our first set of recommendations, and that they're designed to be just the initial step in restoring full visitation, and that we would be working on and submitting additional recommendations for broader visitation. So we stress that to CMS, and as I walk through very briefly what our recommendations are, I want to stress again that these recommendations are just for a very initial step in a broad process of restoring full and broader visitation. So we will be sending out these recommendations after the webinar, so you'll be able to read the full document. But I'm just going to briefly summarize them right now. So first, CMS should require facilities to allow visits by essential support persons. I'm just going to call them ESPs. So this is the idea that there are some residents who need immediate and critical support. And we would almost call this life-sustaining support, if you will, because this is in order to help residents who are experiencing severe declines or significant change. So in our recommendations to evaluate the need for an ESP, to make it less ambiguous and hard to determine, we also propose that that need should be determined by whether there's been a significant change, and that would be based on kind of the long-standing pre-existing regulatory standard, because that which is significant change. Facilities have been required to identify significant changes for years, so it is not a new term. But if a resident meets that criteria, then we're saying that it would be up to the resident and the family to decide whether to designate an ESP, not up to the facility. There are a few other points about the ESP I want to highlight. The visits would continue regardless of cases of COVID in the facility and community, and that's because the idea is that they are essential and they're providing really critical support. So that needs to continue. All residents could be visited, not just those who were COVID negative. There would not be any limits on the length or the number of visits. And lastly, the ESP would undergo the same screening and testing as staff. And that would be subject to testing availability, because we know there's some issues with that around the country. And the ESP would wear the same PPE as staff. So our second recommendation is that CMS should set stronger standards regarding end-of-life visits. And we're just so concerned because we're hearing about so many arbitrary and really cruel, I would say, restrictions that have been posed on visiting someone who's dying. So we're proposing that those visits should not be limited to just people in their very last days or hours of life, and not just limited to those enrolled in hospice. We're calling for families to be notified when a substantial change occurs that would indicate that end of life is approaching, not just giving a call like, half hour before the resident dies, and that these visits could not be restricted in number or in length. So no more you just get a 2-hour visit or one and done. And finally, the third component is designed to get at the problem that we have heard from absolutely everyone and that we see everywhere, and that is the fact that everything is up to the facility, regardless of what the state has directed. We have to end the complete and total discretion that facilities have to deny visitation. So we are recommending that CMS require facilities to allow and facilitate appropriate access. So you'll remember back in March, basically CMS waived visitation rights and essentially replaced them with guidance. So because visitation is now defined only by guidance, and because guidance isn't enforceable, and because the language of that guidance is unclear, facilities can basically do what they want. So we're recommending that CMS revise its waivers and guidance in such a way that it affirms that residents still have the regulatory right, to access and visitation, and that it clearly defined, what limited aspects there are in some kind of a waiver, so that it be very clear and specific. But that the overall idea is that residents still have rights to visit, because right now it's basically those rights are gone. So we were excited to have the opportunity to provide input. We are aware that CMS has also requested input directly from state ombudsmen. They too only had a day to get those recommendations in, and certainly rose to the challenge and have submitted some very comprehensive and detailed proposals. So the bottom line is momentum for change is growing and our voices are being heard, but we can't sit back and put our feet up. Next slide, please. We have to keep the pressure on. We have to keep at it because we are having an impact. So I urge all of you to continue to contact your policymakers really at every level, local, state, federal. Send emails, make calls, write letters, petitions, do all of those so we can end this enforced isolation of residents that we know is resulting in their decline and death. And with that, I'll turn it back over to Lori, although I see that it's already 3:01.
Yeah, thanks, Robin. Thanks for Robin and Eric and Toby for your presentations on the changing policies, on the important advocacy that's being done. I want to remind you that there are a number of resources related to all of the issues that we've been talking about on the Consumer Voices website. Next slide, please, Libby. And also in line with what Robin was saying, continue to share your stories. We know many of you have done that with us on our story page over the last couple of months, and they are critical for the advocacy that we're doing, both with CMS in the states and on Capitol Hill. They need to hear from you, and as Robin mentioned, continue working with your policymakers at every level. They need to hear from you, and you need to continue calling and putting pressure on them. That's what's moving the needle right now on the visitation issue, and we are hoping for better guidance coming forward from CMS, but we still, I think, have a long way to go until we get back to full reopening. So unfortunately, we are past time today. There have been a lot of great questions and chats that have, and discussion in the chat that have been coming. I will ask you for future webinars, please also make sure you're keeping your comments respectful and that we're not attacking each other in the chat. So we'll remind that on the beginning of future webinars, but we do want to have discussion and leave the chats open so that you all can continue talking among yourselves as well. And we'll go through the questions and see if there are things that we can answer or provide additional information on our websites or for future webinars. So with that, I'd like to thank Eric, Toby, and Robin for pulling the presentations today. And we will be looking at when we can come back again with you soon. And also remember that the recording and the slides and the materials that we talked about today are available on the Consumer Voice website. So go to the link that was in the chat at the beginning and you can access them there. Thanks so much, everyone, and have a great rest of the day and a good weekend.